السلام عليكم ورحمة الله وبركاته. صباح الخير everyone. Good morning everyone. It's my pleasure to stand in front of you guys. So my name is Abdullah Al-Rashidi. Actually I'm a section head in the acute setting within our department, the physical therapy department in the King Fahd Medical City. So before getting started, I would like to thank the organizing committee, particularly Dr. Amber and Dr. Sami, for their invitation to stand in front of you guys. And special thank for the Saudi Palliative Society and Cancer Society too. And for you guys to give us a time to listen to our lectures. So we've been already started with the palliative care almost from 2010. There was an invitation from Dr. Abu Saida, he's here with us today. At that time, he just invited us by email, saying, we need a physical therapist to participate with us in palliative care. I just Google it and say what is palliative, and it comes to they are imminent death patients, end of stage patient. So I just start asking myself, so what could we do as a physical therapy with such patient? But once you just go and read more and more about our role in physical therapy with palliative, you'll find a lot. So today I'll try to give you a brief what we are doing exactly with cancer pain. So, so the title of my presentation is Cancer Pain Management from Our Perspective as a Physical Therapy. In the booklet there, non-pharmacological treatment. Non-pharmacological treatment is a huge topic. It might include physical therapy, herbal, acupuncture, relaxation, or spiritual. But we'll talk from our side as a physical therapy. This is the outline of my presentation. We'll give you some introduction, some definition that we need to understand, at least to speak the same language. Sometimes we are using a rehabilitation and physical therapy, the function, disability, impairment, handicap. So we'll try to give you some definition. What does that mean? So we'll go with the definition of pain, facts regarding the pain, classification of the pain, and our role as a physical therapy in managing cancer pain. So it is it's a parallel with the pharmacological treatment. So some definitions, you've heard function, impairment, and disability. So the function is refer to an individual's ability to complete daily survival tasks like walking, toileting, putting on, off clothes. Impairment, loss or abnormality of psychological, physiological, anatomical structure or function resulting from pathology, but still there is no disability. To make it a little bit clear, just to give you an example. One patient coming to your clinic complaining of severe shoulder pain, and your diagnosis was the rotator cuff tendonitis. Yeah, the pain is there, and the structure is impaired. There is some pathology over there in the ligament itself. But the patient continue to have full functional of daily living. He could walk, drive, dressing on, off. The ladies could reshelf the kitchen. The impairment is there, but there is no disability. So we consider the patient is having an impairment, but he's not disabled. The next step is the disability. Refers to any restriction or lack of ability to perform the function itself. Going back to the same example, if the patient with rotator cuff tendonitis continually to have a severe pain, later on he couldn't let's say drive. So we could say this patient is disabled in driving. The ladies couldn't reshelf the kitchen. We could say she is now disabled in such activity. So every disabled patient has an impairment, but not the opposite. So the impaired patient might normal patients. I might get a back pain presently now, but I'm doing all of my daily activities. I have the impairment, but alhamdulillah, I'm not disabled. So our role as a physical therapy with the palliative, we are participating actively with the multidisciplinary meeting. We have like a weekly meeting with our team, with our colleagues in the palliative care. We are providing education for the patient, for the caregiver, and the family too. So we are maximizing remaining function ability. We're trying to maximize the function that remains with our patient. Achieving symptoms control, one of which is pain. Pain is like a main, major, might lead your patient to be disabled. You might find a patient with no physical deficits, but couldn't walk or do any functional activities because of that pain. One of the symptoms is fatigue. Sometimes we have a term they call cancer-related fatigue. There is no pain, no nothing, no physical deficit, but the patient couldn't do anything. He has a general fatigue, general body malaise. And disability, particularly with the palliative care. And some facts about disability, a common problem among hospice care patients. So disability affects all aspects of life, including psychological, spiritual, physical, emotional. It might lead to depression, anxiety, and disability relates to multiple factors. And they found in studies that 35% of cancer patients experience disability. And just an example, 32% need assistance in activity of daily living. 32 of them, they have some difficulties in ambulation. 7% in transfer. All of these disabilities and being a burden in the family and hospital utilization, it might lead your patient to be desiring death. So what is the underlying factor of disability? So we have more than 10 factors. Deconditioning. Deconditioning, it's a common term that we use as a physical therapy, that it's a multi-system failure that induced by immobility. You could find the patient being immobilized for longer period, then later on he got deconditioning. He might have declining in cardiovascular endurance, respiratory problems, might get DVT, pulmonary embolism, and fatigue, and so forth. And the problem with the deconditioning, they found 35% and maybe 35 to 45% of the admitted patients being on bed without any reasonable cause. They're just being in bed and do nothing. But they have no physical deficits. Fatigue, complicated from therapies that might occur and lead to disability, and undernutrition, neurogenic and musculoskeletal problems. Pain is one of the factors and major factor that might get your patient disabled. Bowel and bladder dysfunction, thromboembolic disease, depression, and coexisting comorbidities. So we have already heard the definition. It's unpleasant sensory and emotional experience that is associated with actual or potential tissue damage. It is a gift from Allah subhanahu wa ta'ala. This is, the pain is alarm to tell you have something wrong in your body. You have to get back and dig in and see what is the reason of the pain itself. Some facts about the pain itself. So relieving pain is a leading concern for both cancer patient and palliative team. Not only palliative patients, but every patient. So the main two reasons bringing patient to the hospital are pain and sometimes the decreasing the function or inability to do the activity of daily living. So that's why we are here to give you some information and to share the information with each other how we could relieve our patients' pain. Cancer incidence worldwide is 6 to 7 million per year. Half of them in the developing countries. Above 4 million every year died because of cancer. And they found 3.5 million patients suffer daily from cancer pain. So there is a limited number receiving adequate pain treatment. It has been mentioned yesterday, it's almost 35 in our country, they are receiving adequate treatment for the pain itself. So the death to cancer pain are almost reaching 28%. Continuing the facts about the cancer pain, it might be occur as a result from the tumor itself, or from the diagnostic procedure, or from the therapeutic procedure, or toxicities that might happened after the therapeutic procedures. So uncontrolled pain can affect every aspect of patient's quality of life. Because if the patient couldn't walk, couldn't get up from the bed, cannot interact with the family because of the pain. So it is affecting the all aspect of life, affecting all of the quality of life, causing suffering, might disturb the sleep and reduce physical and social activity and appetite. So the good news is that the improvement in detection and treatment patients are survive for a significantly longer period than in the past. Even though, unfortunately, the quality of life of these patients, the cancer patient, frequently diminished. Even we are sometimes controlling the pain is controlled, the physical pain is controlled, but the patient experiencing more and more diminishing in the physical activity. So that's why you have to think a little bit beyond just controlling the pain intensity. It is not a matter just to control the pain or to decrease the visual energy scale from 10 to 2. So we have to look a little bit further and to assess our patient in pain intensity for sure, and to see the impact of that pain on the patient's mood, endurance, activity of daily living, function, to have a reliable outcome to control our patient's symptoms. So recent evidence suggests that evaluation of effectiveness of pain management plan clinician must move beyond the evaluation the self-reported rating of pain intensity. So we have to look for the effectiveness of the analgesia itself, the safety and the impact on the patient's mode and mobility to function. So sometimes we are using outcomes for physical functions, balance and risk and endurance, and these are some physical functions tools that could be used to assess our patient's functional ability. Am I talking too fast? Huh? Okay. So we've done off with the introduction, the definition, some facts about pain. We'll go now with the classification of the pain. Earlier there was two or three subcategory of the pain. Whether they found 85% of the pain is primary or related to the cancer itself, and 17% secondary pain or secondary to treatment. And they found only 9% are related to cancer. Later on, they come with the symptom-based, syndrome-based, and mechanism-based. So we'll focus on the newest one, particularly the mechanism-based one. So cancer pain symptom-based classification it has been also mentioned yesterday, and it will be mentioned today. There is a continuous, intermittent. Each one has subcategory, no incidence, mixed, end of dose failure, or intermittent. We have incidence, no incidence, or mixed too. Or sometimes they are dividing the pain based on the intensity itself, while it's mild, moderate, severe. The second one is cancer-based, syndrome-based. Just to give you an example, sometimes they are dividing the pain based on the region-wise, with low back pain, abdominal, thoracic, legs, back, neck. Cancer pain mechanism-based classification. So the influence of this classification was evident from 1950s. So it is necessary and important to understand cancer pain and the treatment later on. So identification of three mechanisms of bone cancer pain, whether it's inflammatory, neuropathic, or tumorigenic, aided not only in diagnosis but also the analgesic management. I don't want to go through all of these one because it is well known to everyone. breakthrough pain are categorized into three groups, whether it's controlled background with no breakthrough, or controlled background and breakthrough. So the predominant pain pathophysiology involves three categories, whether it's somatic, visceral, or neuropathic. Somatic it's related to the external structure, to soma, related to the musculoskeletal like structures, whether like tendon, joint, fascia, muscles. It's likely to be felt like a localized, sharp, and superficial pain. Visceral pain related to the internal organs. It's commonly to be felt like a diffused, dull pain. And we've come sometimes across such pain. Patient coming to our clinic complaining of low back pain, but once you assess your patient like thoroughly, you find there is no correlation between that pain and the movement. If the pain is not, there is no correlation between the pain and the musculoskeletal or any movement, or a specific movement, we have to think beyond the musculoskeletal problems. Such patient might get like renal calculi or renal problem or like uterus cancer or something. So we have to like assess your patient like in a thorough assessment. Neuropathic, it's occurs as a result of injury of the somatosensory like receptors, nerve root injuries, spinal cord injuries, and the symptoms of that like category of pain is like tingling, neuropathy, and it might affect the sensory and motor too. So as a physical therapy, you have like a range of treatment options, and the major intervention that we are using with our patient is the exercise, whether like passive range of motion or stretching exercise or strength exercise, endurance exercise, aerobic exercise. And expert physiotherapy use mechanism-based classification, reasoning process of evaluation of pain. Let's see like a common like diagnosis coming to our clinic like back pain. Sometimes we are like dividing the patients based on their like mechanism, whether it's a positional, mechanical, or chemical. Some score they said, okay, it is like a capsular pattern and contractile pattern. Is there any PT here? Is there any physiotherapist? Okay, only one. So, and Kumar and his colleague described 5 operating mechanisms, whether it is central sensitization, peripheral sensitization, peripheral nociceptive, sympathetical dependent pain, or cognitive affective. We'll take one in each one, give you like description, what does that mean, and as our role as a physical therapy, what could we do with such pain. So central sensitization, increased sensitivity of higher order neurons with the absence of peripheral stimulus. The patient get like, let's give you an example like with phantom pain. The limb is not there anymore, but the patient continues to have like pain, although there is no limb. So they said the base of such patient explained the role played by the amygdala, and they said, okay, the pain memory is still there in the brain. Phantom pain and spiritual pain is an example, and they found like Leeds assessment of neuropathic signs and symptom scale is like really reliable and sensitive and specific for such pain. So what could we do as a physical therapy? So meta-analysis showed that the educational material improved knowledge and attitude toward the pain, to change the pain behavior, to educate the patient about the pain itself, and to change the attitude of our patient to the pain itself. Yes, there is no like peripheral stimulus or anxious stimulus or painful stimulus, but we need to educate our patient. Evidence of using TENS is continuously growing. TENS addressed to the central component of cancer pain and very useful adjunct therapy. Desensitization techniques could be used. TENS, for physio. Transcutaneous neuromuscular stimulation. Oh, thank you. So just to give you one example with the phantom pain, yeah, where the patient get like amputated, like let's say below knee amputation. So sometimes as a physical therapist, we have to do like get started as early as possible with such cases, at least to control the phantom pain. One of our like intervention to start with a permanent or temporary prosthesis, at least to start like weight bearing as soon as possible, at least to send some message to the brain that there is no more limb. Desensitization, we could just sometimes use like Velcro to scratch on the end or the stump itself. Yes, it's painful, but it's a matter of like treatment intervention. Peripheral sensitization, whether it's cancer related or non-cancer related. This is some like examples. Our physical therapy role with peripheral sensitization, regardless of patient's prognosis, rehabilitation may enhance function, and attention to safety factors may avoid serious accidents. To give you an example, let's say a patient with L5 for near throat compression. He has like a neuropathic pain, radiculopathy. Yes, there is like peripheral sensitization from it has like a hypersensitivity of the legs. The main problem in the spinal cord. But we could do something. We could do mobilization, manipulation. We could do some core stability exercise to stabilize the abdomen, to stabilize the back muscles in order to improve the outcome of our patient. Neural manual therapy for nerve mobilization. Sometimes we are using like neural mobilization to mobilize the nerve itself. Is there any neurologist here? Neurologist. Because it's a little bit like controversial. Sometimes they said, okay, the nerve cannot like be stretched. And the idea behind the neural manual therapy is like to mobilize the nerve itself in its pathway. And also desensitization is also useful in such cases too. Sympathetic pain, whether it is over or under activation of the sympathetic nervous system, it commonly be felt like burning and throbbing pain. It might occur with excessive sweating and vasoconstriction. So the direct mechanism with cancer pain wasn't yet established. So it doesn't exist our role with the cancer pain with such category, but it does exist with some different cases, particularly with complex regional pain syndrome that may occur. It's a common problem that might occur with stroke cases. The old term of this one, they call it shoulder hand syndrome. So neural manual therapy like sympathetic slump is useful. Thoracic spine mobilization in patients who had spinal dysfunction is also useful. So nociceptive pain, mostly secondary to disuse, deconditioning, and abnormal movement or posture. Yes, I've seen one patient, it's a young patient with Ewing sarcoma of the right thigh, but he didn't walk at all. Although the upper limb and the left side are okay, allowing him to walk normally. But he's sitting on the bed all the time, almost in flexion position, and he got pain everywhere. It's not due to the cancer itself. He has nothing with the cancer itself, but he got pain here on the upper limb because of the poor posture that he had been for a long time. Musculoskeletal pain among breast cancer patients, and this one is, we could sometimes pain behavior. A lady who just underwent mastectomy, and they are trying to protect the wound itself. She's trying to protect the wound to ease the pain. She's keeping her shoulder adducted to protect the wound itself. It has nothing with the surgery itself, but later on they might get muscle imbalance, muscle wasting, dysfunction, and she might lose the mobility of the shoulder itself because of the pain behavior, because of the protection attitude that she got, just to protect herself from the pain. Nociceptive or musculoskeletal pain, they are essentially provoked by specific posture or movement, as I mentioned. So what could we do? Back to the mastectomy patient, usually they might end it with like lymphedema. So we have like an expert therapist or certified therapist for lymphedema treatment. Changing position or education, re-education, what is the appropriate posture or the good posture for such patient to prevent further complications. Relaxation technique, energy conservation techniques. Sometimes we are using like walking aids. Such patient, as I've mentioned, the patient with Ewing sarcoma, we could ambulate the patient normally with non-weight bearing with the affected side. He could like walk normally. So low laser therapy, it has been used. Strength exercise training, range of motion exercise, other physical therapy techniques. We have like multi-like techniques. We have, this one is called like kinesiotaping. This is Midland taping, and this is manipulation, and this is Mulligan technique. This is kinesiotaping. These tapes has no medication at all. Have you seen this one before? Have you seen the colored one? You are not like Cora. It's commonly used with the sport-like people. You could see them like taping the patient. To apply this one, you have like a certified kinesiotaping therapist. They're working the mechanical of the muscle itself, mechanical of the joint itself. Sometimes with such like tape, this one is a strong and tough tape. Sometimes we are using this tape just to offload the muscle itself. Let's say patient coming to you with like a low back pain, severe low back pain, acute low back pain, and you find like a spasm on the paraspinal muscles, you can just tape the patient to offload the problem. Sometimes patient with like patellar tendon injury, sometimes you can just tape the patient in like horizontal like direction to offload, to stop the insertion of the quadriceps itself. This is like a tough manipulation, and you know what is the manipulation and mobilization? You know it, right? Mobilization is like a symbol like mobilizing the joint within the normal range of motion. Manipulation is like a quick thrust. It might exceed the normal range of motion. This is the normal range of motion of my wrist that I need for functional daily activities. But it might like go more. This is the extra one. With manipulation, we could reach the extra like range of motion that we don't need it sometimes in our functional activities. Yes, for sure, this one has like a contraindication. If your patient is fragile, is osteoporotic, you cannot do like mobilization or manipulation, particularly. Your patient might get like fracture because of manipulation. And particularly with like cervical mobilization or manipulation, you have to be really certified. In Australia, a patient who's going to be like taken to the manipulation or quick thrust for cervical segments, they have to sign a consent form. And Mulligan, and this is from my side, is the safest like technique could be used. This patient, this technique, you have to apply it, and there must be no pain while doing the mobilization. The fourth one, or the last one, cognitive affective pain, could be cancer-related or non-cancer-related. Patients with cancer exhibit greater anxiety and depression and reduce in level of function. It is a multifactorial, may related to narcotic or the opioid therapy, and negative impacts. It has like a negative impact on all of daily living. So sometimes we are like treating a patient with low back pain. We found this patient has like a hypomobility in facet joint. We did like mobilization or manipulation, and it's cured. But still the patient coming to our clinic complaining of the pain because he has like a cognitive problems. So sometimes we are doing like cognitive behavioral therapy, like distraction, positive mood, and self-coping. And sometimes to do the exercise, endurance exercise, to pull him a little bit away from thinking about the pain itself. This is a systematic review, the studying the effect of exercise intervention on persons with metastatic cancer. They found it is beneficial for persons with metastatic cancer. Further researchers need to clarify optimal exercise dose parameters. And the other part of our intervention, we could use electrical therapy. Physical therapy generally accept that electrophysical therapy shouldn't be used around or over the cancerous area, because they said, okay, once you apply electrotherapy on the cancer, might grow and increase the growth of the cancer itself. And physical therapy should consider potential use of electrical stimulation or electrophysiology, electrotherapy in cancer patients, and further researches are needed too. So superficial warming and cooling considered to be the safest non-pharmacological option for managing the malignant tumor. All are theoretical risks that might disseminate malignancy by changing the metabolism. So there is empirical suggestion only a temporarily affects hyper sensitivity of the skin itself because of using the hot baths or cold baths. Not only happened with the cancer patient, even with the normal patients. That's why it's acceptable. Application of warm and cold baths can provide further control over symptoms, but again, we need more researches. Electrical stimulation, TINS could be used. They found a minor negative outcomes has been reported. Again, it happened with every patient, not only with the cancer patient. And there is no report regarding the unwanted effects on tumor growth. And we have to consider the placebo of using the TINS itself. Ultrasound, it's absolutely contraindicated because they found that it might stimulate the tumor growth and dissemination too. So laser therapy could be used not only to relieve the pain, but they found a protective or even an inhibitory effects on malignant cell proliferation. And the last, some message that we need just to share with each other, always consider patient description, as mentioned yesterday by our colleagues. If your patient thinks he has a pain, you have to stop and ask to have more clarification, to understand what is that pain, whether it's a neuropathic, visceral, or somatic pain. So what is the reason behind that pain, and how you could help your patient. Sometimes your patient coming to with neck spasm, you say, okay, this is a normal muscle spasm. Because you compare the sense of feeling with yourself. So their pain threshold are not equal. So full assessment is the key and important. And again, we need to think a little bit beyond decreasing the pain intensity. We have to think about the impact of the pain and how we could improve our patients' endurance to be more independent in activity of daily living. There are a need again for further researches for the application of the electrotherapy with cancer patients and the exercise, particularly the doses and the frequency too. I think we end. Thank you so much.